So it's just after 8. So welcome everyone to today's edition of Nephrology Grand Rounds. We are really excited to have Dr. Perry Wilson from Yale. Perry is the methods man. You may have seen him on CNN. He has a regular column in Medscape, and he's got his own YouTube channel, Methods Man MD, which I would encourage any one of you who's interested in stats and epidemiology to check out. But in his regular life, he is the director of Yale's Clinical and Translational Research Accelerator, which is kind of a multidisciplinary human subject research collaborative. He uses data science, machine learning, digital health device, all the high tech stuff, along with the core epidemiology and translational research methods in making care delivery more efficient with data science approaches. He's done several trials in the AKI alerts phase, and I think he's going to talk to us about his research program around that area. Welcome, Perry.
Thank you so much, Swap. I'm so glad to be here with all of you today, and I'll jump in. I'll get started, and you can tell me if my slides aren't showing properly, but I think they should be. So, great. I'm going to talk to you today about alerts in the context of acute kidney injury, which sometimes people refer to as clinical decision support. My research portfolio has certainly expanded a bit around AKI. We've done trials now in alerts for heart failure patients and in alerts for hyperlipidemia and people with high-risk atherosclerotic cardiovascular disease, all of which I'll say are easier than doing alerts for acute kidney injuries, as I've learned, and I'm going to try to explain why. And if you want to, if you're the type that skips to the end and you like to know who the murderer is when you're reading the mystery book, that's what this slide is for. So this is what I've been calling the grand unified theory of electronic alerts. The sort of stuff that we've learned that might seem common sense, that we've realized over time that you really need to think about when you're building alerts. This is the end of the talk, and then I will tell you how we kind of got to this point, giving you some examples from our own studies. But basically, alerts for anything cannot work if the provider you're alerting already knows what's wrong with the patient, right? So the first thing is, it has to be a surprise. You have to tell them something they don't know, or otherwise you're simply reinforcing the belief they already have. If they don't know, that's great, but they also have to care about the thing you're alerting them about. It can't be extraneous. It can't be nonsense. It has to resonate with them. And then even if they care, they have to be able to do something about it. I see this a lot in the machine learning literature where you have, predictive models that might be highly accurate about something very important like death or ICU transfer or something like that. And yet, if there's no action tied to that warning, you might care a lot. But if you have nothing to do, your hands are tied and it's not going to make a difference. And maybe the trickiest part in the case of acute kidney injury is that even if there is something you can do, that thing has to matter. It has to change outcomes, and ideally has to change outcomes at the patient level. That means you need a treatment for the underlying condition. So a bunch of hurdles. Now, people ask me what my lab does. These days, I call it interventional data science. This is really applying data science tools like real-time analytics and machine learning to target interventions to patients at the point of care. That's the broad theme running through. In this case, we're using real-time analytics, and our intervention is an alert, a clinical decision support system of some kind. So I'm going to zip through, I think, 4 study designs to sort of show you what we've learned over time. And I'm going to spend more time on the later ones because there's a bit more detail. So we're going to start kind of at the beginning and very quickly talk to you about our first real multi-center AKI alert trial, our simplest trial, which was called ELIA-1, where we wanted to do a rigorous evaluation of a common sense intervention. And so the way I justified this study to the IRB and to the funding agencies that cover it is things that you probably already know, which is that AKI is bad. It's quite common in hospitalized patients. About 15% of patients in our hospitals will develop AKI based on this KDIGO definition, which is in the blue box that you've all probably memorized at this point. But you may not realize that the association between acute kidney injury and inpatient mortality is incredibly strong. So it's someone with AKI has a 10% inpatient mortality rate at our hospitals here, versus 1.5% for people that have at least 2 creatinines. So people who are really admitted to the hospital and are getting blood tests, who do not have AKI. And there was some literature to suggest, mostly observational, although one randomized trial, to suggest that maybe recognizing AKI earlier, getting nephrologists involved earlier might improve clinical outcomes. So we first asked a question retrospectively just to say, can we answer that question? Do providers know that their patient has AKI? That's that first step of the grand unified theory of electronic alerting. Do providers know that their patient has AKI? And we think the answer might be no, they don't, at least in some cases. If you look at chart documentation of acute kidney injury, these are 3 of our hospitals in the Yale system, representing 29,000 hospitalizations with creatinine-defined AKI. You can see that chart documentation of acute kidney injury is fairly low. It's around 30% across our 3 major hospitals. We joined up with Jay Coyner at the University of Chicago to do a multi-center retrospective study looking at best practices in acute kidney injury, because you might say, yeah, just because someone doesn't document acute kidney injury doesn't mean they don't know it's there, right? They might be aware of it. They're just, not writing it down. And that's fine. So we looked at some more concrete things to see, how likely people would be to do these best practices, which you can see here. Things like documentation, urinalysis, subsequent creatinine monitoring, urine output monitoring, and a broad category we call avoidance of nephrotoxins, which included things like contrast media and aminoglycosides. These were patients with stage 2 acute kidney injury, so a doubling of creatinine. These are pretty real people, real AKI, we would call it. And you can see the rates of some of these best practices, including things like urinalysis, which is pretty universally recommended for people with AKI, is pretty low. And then one of the things that got us kind of more concerned is if you look at, for example, the NSAIDs pie chart. What this shows you is we identified people who were on NSAIDs when the AKI developed. And we just asked the question, what percent of these people got at least 1 more dose of NSAID within the following 24 hours after the doubling of creatinine? And so, that dosatoridol that most of us would say you probably shouldn't have gotten. And it was a significant proportion, 41%. So that was our first step to say, okay, we think this is getting missed. AKI is asymptomatic. It's not a tough diagnosis to make, but you got to do a little bit of math in your head if you're looking at the change in creatinine. So it was kind of a simple step to ask the question, maybe alerts would be a solution. But we do want to analyze these things rigorously, and the most rigorous form of analysis for us would be the randomized trial, which is how we developed ELIA-1. So we developed an automated alert system that would identify people with AKI, and then the system itself would randomize the patient to either an alert or a usual care arm. We looked at a variety of process outcomes. This will be a recurring theme in these studies where we look at things that people do in response to an alert, like ordering that urinalysis, but more importantly, clinical outcomes, including progression of AKI, dialysis, and death, which is a composite outcome we've used in several of these studies. This is what that original alert looked like. You'll see the typical, I don't know if you're an Epic shop up there, but this is the typical, this is the typical Epic color scheme. We often get a lot of good feedback about the sort of user interface of the alert, and unfortunately it's not as customizable as I would like within the Epic ecosystem. Things are improving though. But what you can see here is that you get some information about the current creatinine and the lowest in the past 7 days. That's patient-specific information. You have some boilerplate here telling that the provider that this is a randomized trial. You have the option to open an AKI order set and to add AKI to the problem list, and of course to agree or disagree and tell us why you don't think this patient has AKI. We enrolled 6,000 people over about a year and a half in this study. You can see roughly 3,000 in the alert and control group. There's no loss to follow-up because all the outcomes were assessed on the inpatient side. So we have that advantage. But before I give you the results, I'll just show you sort of how we manage. This is a little how the sausage gets made of how we manage these studies on the back end. Real-time research is great. You've got an algorithm running in the electronic health record. It's live. It's enrolling people every day, dozens of people every day, in this case, under a waiver of informed consent. So it's kind of a set it trial, and it's running, it's accruing data. But it's not set it and forget it. We look at a variety of metrics on a weekly basis in all of our studies just to make sure things are working correctly. I'll give you an example of when they don't work correctly. So here, for example, is a chart showing the median number of alerts each week at the patient level across the 6 hospitals that we had randomized. And what we're looking for here are big spikes or big dips, like if you look at week 59, when everything kind of goes to 0, which is a hint that something has broken in the system. And things really do break. Epic and any electronic health record system is not designed to be a rigorous platform for randomized trials. We're kind of hacking our way into that. So we follow a variety of metrics: the number of patients randomized, of course, the number of providers who see alerts, the alerts per patient, the alerts per provider, the alerts per location. We have a second AKI sniffer that operates on a different data source to validate the first one, and so on and so forth. And it's important to note that variables can break when you do studies like this. So here's a real life example. We had a variable in our data set called lag. Now, the way this study worked is that the alert would fire when someone opened the chart of the patient. That would happen at some point after the creatinine result came back that defined AKI, right? Because you can't have AKI until you have a creatinine result. But the patient wasn't enrolled until the chart was opened. So there's a delta in time between the result of that lab and the next time someone opens the chart, which is when the patient's enrolled. And typically, I think the median lag was something like 30 minutes or 20 minutes because people open the charts all the time. So it's kind of a nuisance variable. We tracked it, but nothing very interesting until we saw these negative values coming up. So that means that the patient was randomized before they had AKI, which is obviously strange. Did the system become self-aware? Have we invented Skynet? We hadn't. You can see that these all happened on the same day. And that's a hint that something has gone wrong here. So on a hunch, I emailed our clinical chemistry laboratory person, Julie, and I said, hey, did something happen with the creatinine assays on June 22nd? And she said, oh, yes, we had some corrections made that day for creatinine. The reagent volume was incorrect, but all the patients that were affected during that period were repeated and corrected, and corrective actions been taken. It won't happen again, et cetera, right? So this is lab error. Of course, so what really, what happened is some people's creatinines got measured too high due to lab error. And the alert system does not know that, right? It doesn't anticipate that there will be lab error. It just sees a higher creatinine, and that's AKI, and so it enrolled the patient. And then subsequently, those were all corrected, and so when we pulled the data, we pulled the corrected creatinine data, and it led to these errors where it was like, no, this patient doesn't have AKI yet, their creatinine is normal. So a false positive alert, even though it's a very simple algorithm to detect a change in creatinine, it's worth remembering that. Okay, results. So our primary outcome was a composite of progression of AKI, dialysis, and death, which you can see here. I'm showing you the absolute event rate. These aren't on the relative risk scale. This is just absolute event rates. And we had pre-specified that we were going to stratify our analysis by our teaching versus non-teaching hospitals, on the idea that honestly, we thought alerts might be more effective in our non-teaching hospitals, not because the care is worse, but because in the teaching hospitals, you have a whole team of people rounding on the patient. You've got many sets of eyes looking at that creatinine, and we just thought probably someone will notice they have AKI. That talented medical student is gonna bring it up. Whereas in the non-teaching hospital, you don't have that. Nevertheless, quite the opposite here. Oh, sorry, I thought I highlighted that. But if you look at the composite outcome rates, pretty similar or all the outcome rates, pretty similar in our teaching hospitals, but in our non-teaching hospitals, a higher rate of actually death in the alert arm compared to the usual care arm. And of course, that translates into a higher rate of the composite outcome. A complete surprise and something very concerning to us, obviously, when we saw this. And as nephrologists, you're all no doubt thinking already of all the possible explanations for this finding. And I'm going to disappoint you with our mediation analysis and not explain what happened here. So the way we do a mediation analysis is we isolate the observed effect. In this case, I'm showing you the adjusted relative risk of death in those non-teaching hospitals. So we're just looking at the non-teaching hospitals. You can see the alert group had a 1.58 relative risk of death compared to the control group in those hospitals. And then we examine various potential mediators to look at how accounting for that mediator attenuates that adjusted relative risk of death. That's sort of how these mediation analyses work. So my number 1, 2, and 3 thoughts when I saw these results were, this is IV fluids. We're alerting people, they're flooding these guys with fluid, everyone's going into heart failure. This is what's going wrong. And so we looked at various markers of fluid overload from the administration of IV fluids in just sort of a yes/no format, or the total amount of IV fluids, or proxies for oxygenation like the O2 sat, or even the change in O2 sat, or the respiratory rate, or the change in respiratory rate. And basically what you see here is there's no effect. It does not appear to be fluids that caused this problem. So we looked at other things like medications or the avoidance of medications. We looked at process factors, including renal consult. I had read too many James Patterson books and had thought, okay, it's obviously, the renal consult is secretly killing people. It was not that either, as you can see here. So I don't have an explanation. And what that means is a couple of things. Number one, we just haven't thought of the right thing yet to test for. Number two, it could just be bad luck, right? This is a subgroup analysis fundamentally, and you get statistically significant results in subgroup analyses. These things happen. The other thing I want to point out is, as sort of a thought experiment, is what if I had shown exactly the opposite effect? What if I had just told you that in the non-teaching hospitals, the relative risk was 1.58 against control, so a benefit in the alert group. You might have asked what mediated the benefit, but if I showed you that nothing really did, you probably would have thought, well, that's okay. You alerted, there's probably a bunch of things, people paid more attention, they just kind of took more care. And in some patients, maybe it was a medication, and in some patients it was something else. And you're never going to pick out one thing that mediates the benefit of an alert. And if you would have been willing to say that, you probably have to be willing to say the opposite of that, which is that it might be hard to pick out one single thing that mediates the potential harm of an alert. Nevertheless, take-home points here. We can do real-time clinical research. It's efficient. It's cost-effective. We recruited 6,000 people in a year and a half. That's pretty good. These are highly pragmatic studies, right? This is, there's limited exclusion criteria here. The information is actionable. But of course, the results may surprise you. Now, that's, I would argue, a good thing. This is why we do trials like this. There are people that told us before we started the trial that it would be unethical to not inform the providers that their patient has AKI if we knew. How could you keep that from them? And this is the reason, because until you test it, you don't necessarily know if there will be a benefit. So after we published that, we were maybe a bit disheartened and sort of started thinking about why we might, not see much benefit from informing providers. And remember, we believe providers didn't know their patient had AKI. We satisfied that first step in the grand unified theory. We believe that providers care about AKI. They tell us that in surveys and things. But then we were starting to think, okay, what are they supposed to do, right? What we told them the patient has AKI. What are they supposed to do about it? And in 2019, Nick Selby came out with a nice step-wedged randomized trial from the UK across 5 hospitals, looking at an automated AKI alert, but coupled to what he called a bundle, which we often in the United States call like a checklist. Anyone who's read the checklist manifesto, right? So we are not only going to tell you that your patient has AKI, we're going to give you a very specific list of things to do, such as medication review and fluid assessment and urinalysis that you can kind of check off to say, yes, I've done my due diligence regarding AKI. The study enrolled 24,000 people across 5 hospitals. And you can see from the bar charts here that it did move the needle in terms of AKI recognition, medication review, fluid assessment, urinalysis. These are all things that were on that bundle. So, if you tell the provider to do something, a lot of times they'll do it. What that didn't translate into, maybe this is step 4, which is, the thing that you do, the action has to matter. It has to change outcomes. It did not change 30-day mortality in these patients or AKI progression. There was a reduction in hospital length of stay, and there was improved diagnosis of AKI and delivery of AKI care. So process outcomes, the needle was moved. Clinical outcomes, not so much. But we did take a lesson from Nick here to say, okay, we need to couple an alert to some specific action the provider can take. And the low-hanging fruit for us was nephrotoxic medication. So this led to ALIA 2, where we coupled the alert to specific drugs. And so you can see this a bit of a different format and in the alert here. We're showing you an alert for a patient. We're still telling you what the creatinine is and how much it's changed, but now we're telling you what drugs this patient is on with some very carefully worded language, which just, again, how the sausage was made. We went back and forth quite a bit with the IRB about the language of this to make sure it's a low risk intervention or a minimal risk intervention. We had to give a lot of autonomy to our providers. So it's, ASARB, these medications decrease pressure in the glomerulus, decreasing GFR. If you stop this, maybe think about some other antihypertensive, the PPI. Hey, these medications have been linked to acute kidney injury and chronic kidney disease. So we're kind of saying, hey, maybe think about this, and a link to the medication order entry. We picked not every nephrotoxin, and this is something people ask about a lot. We only picked 3 classes. There are many more nephrotoxins than NSAIDs, renin-angiotensin system inhibitors, and PPIs. Many of you are likely looking at PPIs and saying, wait, that's not a nephrotoxin at all. This was deliberate. One of the reasons is you might think, or we all might think we know what a nephrotoxin is, but actually coming up with a real list is very, very challenging. Sure, aminoglycosides, although they're rarely used and so wouldn't contribute much to a trial like this. But what about things like Zosyn and vancomycin, or God forbid the combination of Zosyn and vancomycin, which might have synergistic effects at the kidney and things like that? It gets incredibly complicated very quickly. We wanted to keep this clean. And so we envisioned this really as 3 trials in one. A trial of NSAID cessation, which is something that everyone agrees you should do in the face of AKI. An interesting trial, and Swap knows that it has been in my heart for a long time to do a trial of ACE inhibitor stoppage in acute kidney injury. The reason being, although a lot of people do tend to stop ACE inhibitors in the hospital when someone has acute kidney injury, there's a physiologic reason to think you might want to continue them, which is to say that the use of ACE inhibitors increases renal blood flow. And because your tubules are, presumably, at least in ATN, your tubules are, getting starved of oxygen and might benefit from extra blood flow. Maybe ACE inhibitors are actually therapeutic in the case of AKI. So I was very curious about that. And then proton pump inhibitors, because our group has a particular interest in AIN and actually believes that there's quite a bit more what you might call subclinical acute interstitial nephritis, both in and out of the hospital than people might be aware of. And so 3, maybe unusual or bespoke choices. But basically the idea was identify people with AKI on one or more of these 3 classes, and target the alert to those people. So this was a trial that randomized just over 5,000 people, very similar design to what I showed you for ALIA 1. Some inclusion-exclusion criteria here, very minimal, pragmatic clinical trial. You had to be an adult. You had to have an active order for one of the medications. We excluded people with transplant on hospice and so on. The primary process outcome was the cessation of at least one of these medications within 24 hours of randomization. So did you stop it? And then the clinical outcomes are standard composite of progression of AKI dialysis or death. A variety of secondary outcomes here. And I'll point out, kind of in addition to this one, we had some pre-specified safety outcomes because this was a little more interventional than our last alert. We're asking you to stop a specific medication and there might be off-target effects. If we stop NSAIDs, are people going to use more opioids, which could be a problem? If we stop angiotensin system inhibitors, is there going to be more hypertension or pulmonary edema, which could lead to mechanical ventilation? If we stop PPIs, are we going to have people having GI bleeds? So we're looking at things like hemoglobin levels and blood transfusions. This is a typical AKI population in our health system, 70 years old, about half male, half female, 20% Black, mostly medical admissions, but a quarter are surgical admissions and a quarter of people are in the ICU. Just to show you how this kind of broke down, this is the Venn diagram of our 3 medications of interest. The biggest group is proton pump inhibitors. They're, of course, given out like candy in the hospital. I heard someone refer to proton pump inhibitors as the mint on the pillow of a hospital admission. Everyone gets one. And then you've got, a slightly less angiotensin system inhibitors and then more NSAIDs even than I would have appreciated. I think as consulting nephrologists, we often don't see how much NSAID is used because it gets stopped before they call us, but it is out there. And then there's obviously some overlap. So looking at the process outcome, the scale here goes from 0 to 100%, so it might not look that impressive, but we did have a statistically significant increase in the rate of discontinuation of these medications across all the categories. The composite is on the left here, and you can see this both on the absolute scale on the left and then on the relative risk scale on the right. And I'll highlight proton pump inhibitors down here. No surprise that these overall are discontinued less than the others because it's just not in people's heads to stop proton pump inhibitors in the face of AKI. But on the relative scale, it was the largest increase. The effect of the alert was the largest among the proton pump inhibitors. Zooming over to the clinical outcomes, you can see overall that actually our composite outcome rate was improved in the alert group numerically. The relative risk is 0.92, but you can see this is not statistically significant. We did pre-specify, as you might expect, that we were going to look at each medication class as its own, the 3 trials in 1. And we do actually see a clinically significant benefit of alerting in the PPI group with a relative risk of 0.88 for progression of AKI dialysis or death. Interestingly for me, just on the angiotensin system inhibitor, not a whiff of signal here in terms of clinical outcomes. And this is not published, but I explored, various subgroups and people with heart failure and, other kind of reasons to give ACE inhibitors, and really nothing shook out that I think is worth, that would count as generalizable knowledge. But this trial made me, I'd say, less enthusiastic about our reflexive discontinuation of ACE inhibitors. It doesn't seem to matter very much. More studies are needed. That's my safety valve, but I don't think it's mandatory to stop ACE inhibitors in the face of AKI, all else being equal. In terms of our secondary outcomes, I won't go through them all. I'll give them here. In general, you can see some modest effects without much statistical significance. And then our subgroup analyses, if you kind of blur your eyes, you can see that the broad effect is pretty similar across all subgroups. The only exception, I will say, is this interesting baseline creatinine, low baseline creatinine subgroup. This is only I don't like to overinterpret subgroup analyses, but this is only interesting because we've seen it before in other studies. And I'm actually going to show you in the next part the study that also found this interesting finding, and I'm going to speculate why there might be some juice in this low baseline creatinine group. Talking about safety outcomes, those things that we had pre-specified to look at just in case. What you can see, for example, in the NSAID group is that the opioid prescriptions were exactly the same. I mean, high, 70%, but the same across both groups. The maximum pain scores were very similar across both groups, also high. These are people who are receiving NSAIDs. They are in pain, but it didn't seem to matter if they were alert or usual care. No differences in blood pressure or mechanical ventilation in our ACE inhibitor group, and no signs of GI bleeding or increased transfusions or differences in hemoglobin in the proton pump inhibitor group. I don't want to overinterpret the PPI finding here, but there's some reason to think this might be real. Of course, the alert effect was strongest amongst the PPI group, at least on the relative scale. As I said, the reason we even had the PPI group in this study at all was because we thought that it was an under-recognized contributor to AKI in hospitalized patients. So maybe this bears out that hypothesis. Of course, subgroup analysis, this could be alpha error. This could just be a false positive. It should be replicated. I have a grant under review that might just do that, but we'll see. But of course, also, let's remember that patients receiving PPI are different than patients who don't receive PPIs, and I'll sort of show you that here. This is from the ALIA-2 trial. People receiving PPIs on the left, no PPIs on the right. So this is not randomized anymore. This is someone chose to prescribe PPIs. And what you can see is that the people on PPIs are a little bit more medical than surgical. They're more likely to be in the ICU, more likely to have CHF, have a slightly higher creatinine at admission, and a higher modified SOFA score. So, broadly speaking, people on PPIs are sicker than people not on PPIs. I'm not entirely sure what that means or why alerts should work better necessarily in people who are generally more sick. But it's worth remembering that it might not be the PPI effect. It might be that PPIs flag a different population of patient. So our take-home points here, we know that alerts can increase the rate of cessation of potentially nephrotoxic medications without endangering patients, but limited evidence that these alerts change clinical outcomes. Maybe there's something among our PPI users. So seeing these kind of modest effects led us to start asking a question, or to start being concerned about what's often referred to as alert fatigue, right? Let's say there's a benefit of these alerts, a modest benefit. Well, how many people do you have to alert to, get one person to not have progression of AKI? And is it worth it? Because alerts are kind of annoying and they distract providers from their from whatever it was they were meaning to do in the electronic health record in the first place. Can we target alerts better? And so I wanted to take a minute to talk about a concept which is in the marketing literature known as Uplift modeling. I think only people who have an MBA after their name might have heard of this, but in medicine, this is sometimes called as individual treatment effect modeling, which makes more sense. But actually, I think it's better developed in the marketing literature. So I want to take a little diversion to talk about how we can better target alerts using data. But I'll give you a warning. This is a direct quote from someone who reviewed our paper. Why the authors think an extremely convoluted technique developed in marketing should be taken seriously in clinical research, where highly competent statisticians have developed techniques over decades of research, is mind-boggling, which is this is pretty rough. So there you go. For reviewer threes out there, you can turn off your screen for a little bit as I go through why we think this might be useful. All right, so how does Uplift modeling work? Well, let's pretend we're marketers. We're the marketing department for a major diaper company. We sell 100,000 diaper boxes per week, but of course, management, breathing down our necks, sell more diapers. We launch a coupon campaign. There's our diapers. Okay, so we're going to launch a coupon campaign. And we look at our sales, and here's our diaper sales per week, pre and post coupon. And certainly, looks to me like sales went up after we released our coupon campaign. And you could do a study of this. You could test this statistically, right? This is a standard kind of before after design. Excuse me. A lot of people do studies like this with alerts, right? You don't have an alert and then you turn on the alert and see if things change. But course, that's not highly rigorous because maybe there's a secular trend overriding this, that just diaper sales are going up already. And marketers actually know this. They figured this out long ago. And so what they do is something they call A/B testing. We call it randomized trials, whereby they take everyone on their very detailed mailing lists and they send 50% of them a coupon, and they don't send 50% of them a coupon, and then they track their purchases. And your purchases are being tracked because every time you go to the grocery store, you scan your little membership card to get your discounts. And so now they know everything you've bought, whether you're in the coupon group or not in the coupon group. And so now this is a rigorous randomized trial that shows the difference in sales between the coupon and no coupon group. And marketers have done basically, the type of study that if this were a cancer drug gets you into the New England Journal of Medicine. So marketing team, very proud of themselves. They present to the higher ups. They say, look at this, our coupon promotion significantly increased sales. They can put statistics on this with p-values, $100,000 to $120,000 per week. And if this were a medical study, we would stop and we would say coupons are good. We've proven coupons are superior. Everyone gets a coupon. And this is where the diaper company is ahead of medicine, because the higher ups don't say that. What the higher ups say is, wait a second, how much do the coupons cost? And wait, we can't send everyone a coupon because a lot of people are going to buy the diapers anyway. We don't want to send them a coupon. And some people might not like getting coupons. What if the coupons kind of turn people off? So are we going to send them to everyone? And this led to a concept called the marketer's dilemma, which I sort of schematized in this 2x2 table, where on one axis you have the likelihood of buying a product or diapers with a coupon, and on the other axis you have the likelihood of buying the product without a coupon. And in the upper right-hand corner, you have what are called sure things. These are people who are going to buy your diapers. They'll do it with a coupon. They'll do it without a coupon. You've got the lost causes here on the bottom left corner. These are people, very thankfully, like me at this point in my life, who will never buy a diaper again. Knock on wood. And then you have people up here. This upper left-hand corner. These are people who are more likely to buy the diaper without a coupon than with a coupon. Seems strange. They call these sleeping dogs. More relevant for luxury goods. So these are people who, by receiving a coupon in the mail, are going to be less likely to purchase. So it's like, oh, I don't want diapers that cost less. Diapers a bad example, but if you're thinking of like a watch or something like that, you might not buy the watch that you got the 20% discount on because it seems like it's less luxurious. And then here is your real, the group you want to target. These are called persuadables in the marketing literature. So the people that wouldn't buy the diapers, but if they got that coupon, you'd push them over the edge to a buyer. And if all you did was send coupons to these people, that's the optimal strategy. And there's a direct link between this framework and medicine. And I'll spell it out here. They are trying to maximize profit. We are trying to maximize lives saved. They are using a coupon. We're using a medication or an intervention like an alert. The fundamental insight is there is a way to make more money by sending less coupons, right? If you send coupons to everyone, you don't maximize your profit. The way you maximize your profit is sending coupons only to those people that it'll change the outcome. Similarly, in medicine, it is possible to save more lives or improve your outcomes in a population by giving less people the medication. Medicine and marketing paralleled each other up to and including the randomized trial, but marketing has moved ahead. They've realized that you need to personalize who you target this to. So is this just subgroup analysis, right? Like we do a trial and then we have some pre-specified subgroups and we detect a signal and we say, okay, this works best in people with, you know, diabetes or something. And so now we're gonna do it in only in people with diabetes. This happens a lot. You guys might remember. Oh gosh, this used to be so like timely, and now I'm old and no one probably remembers activated protein C swap. You remember activated protein C. You know, for sepsis, the Prowess study, which was negative, but an interesting subgroup in the severe septic shock group that suggested a signal of benefit, which led like 10 years later, 9 years later, to the APC in septic shock actual trial, which was negative. So it's like, it took us 10 years to validate this subgroup analysis finding. And I don't think we're using activated protein C at this point in time. But uplift modeling is not really just subgroup analysis because it's multivariable. So an uplift model takes multiple variables, not just yes, no, do you have shock, and creates a single score from it, like a regression model. So traditional subgroup analysis is limited to one or two categorical variables, right? Like, oh, patients with shock and who are greater than 70 or something like that, which really limits your sample size, limits your statistical power, doesn't have any appreciation for the spectrum of a disease. But we can actually do this in a multivariable context, and I'll show you how that works. But before I do, you know, people ask, wait, shouldn't you just target people at highest risk? Like, don't interventions always work best in people who are at highest risk of the outcome? And there's an intuition there, I get it, right? Like, we only give warfarin to people with AFib who are at the highest risk of having a stroke. So that intuition makes sense, but it's actually not true. And there are myriad examples where interventions work better in people at lower risk and not very well at people at high risk. For example, tamoxifen. So let's say you didn't know how tamoxifen worked. You didn't know it was an estrogen receptor modulator. But you did know that women with breast cancer were at much higher risk if they were ER receptor negative, which is true, right? And so if you were designing this trial of tamoxifen and you just wanted to quote unquote enrich for high risk people, you would just exclude people who are ER receptor positive because they're lower risk in general, and you would show that tamoxifen doesn't work. So there's lots of examples like this. You know, do smoking cessation interventions work very well in people who have metastatic lung cancer? You know, like, you can kind of think of all of these things, but there's no a priori reason to assume that any intervention works best in the highest risk group. So this is not about modeling your risk of outcome. It's actually about modeling the risk of or modeling the benefit of the intervention. So to demonstrate how we did this, I'm going to take data from a pilot trial even before ELIA 1 that we did on AKI alerts. This was a single center trial, stratified randomized trial. This was the old days. We were just texting people. You know, it was an automated text, but it was just, you know, a little text that said, hey, your patient is AKI. Didn't show up in the electronic health record. But I want to show you the real data, show you how it works. So here are counts of outcomes in the usual care and alert group based on progression of AKI. And I'll tell you, this was a negative study. That there was no difference in progression overall, no statistically significant difference. But let's think of where we put in this framework those people. So those sure things are here, right? That if you're a sure thing, you're going to do fine no matter what, whether you get an alert or not. So those sure things are distributed theoretically evenly across this first row. And conversely, our lost causes, the people who are going to have progression of AKI, regardless of whether they get the alert, are in this bottom row somewhere. Where it gets interesting is there are sleeping dogs, which are going to be on the cross products here. These are, they're the people that are going to do fine if we don't alert them, but they're going to have more progression of AKI if we do alert them. I'm not sure how, but theoretically that's where they would be. And then, of course, those persuadables, the people we really want to alert, live in this diagonal. And so what we can define then is these are the types in green are the types of people we would want to send alerts to, because that's where all our persuadables are. Now, sure, there are sure things and lost causes in these boxes. We cannot tease them out. We don't know a priori who they are. But that said, we're not going to change their outcomes anyway, right? Because they're sure things and lost causes. The alert has no impact on them, but it does on these persuadables. And so we define this these green boxes as, you know, what are these types of patients? How can we phenotype the groups that fall in here. And there's a variety of methods to do this. We use something called an Uplift random forest. And I will sort of skip to the end to show you that we can create 5 categories. And this is in a held out test set from this trial. And if you just look at the extremes, what you can see is that among the people that we predict would be harmed by the alert, if they got the alert in the trial, they do worse. And among the people who we think would benefit or likely benefit, if they got the alert in the trial, they did better in terms of AKI progression. If you want to look at like how this would look if you narrowed your trial inclusion criteria from everyone with AKI to just the top 80% likely to benefit, top 60% likely to benefit, top 40% likely to benefit, top 20% likely to benefit, this is what those curves look like. So this is an example of enriching a trial, not for the outcome rate, but for the benefit of the intervention. So who are these people? Like, what does the model say? Now, it's this is an Uplift random forest, not the most interpretable model in the world, but if you just categorize the difference between likely harm and likely benefit, what you see is from this study, the people are older, they're much less likely to be male, and they have a lower baseline and randomization creatinine. So there's that signal again that I sort of telegraphed we were going to end up with. So, in my head, I'm like, oh, these are those little old ladies with low baseline creatinines, right? Those ladies who come in with a creatinine of 0.4, their creatinine goes to 0.8 or 0.9. Does this make sense? I think it does. Remember, the first step of alerting is the person has to not know the thing you're alerting them about. If they already know the patient has AKI, then alerting them that the patient has AKI cannot possibly do any good. And so these are people whose creatinines look normal, right? They're not flagged. They don't turn red in the electronic health record. And more importantly, in the mind of the provider, a creatinine of 0.9 is normal. But to us, as nephrologists, we know, well, if you start at 0.4 and you're up at 0.9, like that's pretty significant AKI right now. And so that seems to be who the data is telling us these alerts benefit. Just kind of an interesting finding there. Can we prove that this works prospectively? We can. We're trying. You're going to hear about a trial that started literally last week, our first Uplift targeted trial. So you can do this in 2 ways. Number one, you can do a trial where an inclusion criteria is having a high Uplift score. And so you basically do ELIA 1 all over again, but instead of everyone with AKI, it's everyone with AKI plus high Uplift score based on the model that we built. And then you look at the effects. You look at the relative risk in alert versus control in this new trial, and you show that it's better than the old trial. But the problem is, especially now, like ELIA 1 was pre-COVID. This is post-COVID. This is years later. Like if we got a different result, let's say that we got a relative risk of 0.7 or something like that, like, is it that Uplift works or is it that alerts work now because everything's gone crazy? We decided to go with something called policy-based randomization. So everyone gets enrolled. 50% get randomized to do what the algorithm says, and 50% get randomized to do the opposite of what the algorithm says. So this is a policy-based. We're not randomizing to alert versus control. We're randomizing to follow the computer versus do the opposite of the computer. And this is what it looks like. So this is ELIA 3. We are live across 6 hospitals right now, recruiting patients. Every patient with AKI is included, with those generic exclusion criteria, and an Uplift score is calculated for each of them. You can see some of them are blue. We predict they'll be benefited by getting an alert, and some are red. We don't think they'll be benefited by getting an alert. Then they're randomized. If they're randomized to the do what the computer says group, well, then the blue people get alerts and the red people don't get alerts. If they're randomized to do the opposite of what the computer says to do, then the blue people don't get alerts. And the red people, the people we think will not benefit, do get alerts. And so the unit of analysis here is we're going to tell you at the end of this trial, of course I don't know the results, we're going to tell you at the end of this trial whether randomization to follow the computer is a good thing compared to randomization to don't follow the computer, in fact, do the opposite of the computer. Interesting little tidbit here. If you look at the alert group in the end, like who's getting alerted, it's actually a random assortment of people who we predict would benefit and wouldn't benefit. And the no alert group is also a random assortment of people we predict would benefit and wouldn't benefit. So in fact, functionally, this is a LIA 1. Again, it's just that instead of the unit of analysis being alert versus no alert, it's the randomization to recommended versus anti-recommended. Very excited about this. Complicated, calculating the prediction of benefit in real time. We'll see, but we're recruiting actively. Last story, just to show you sort of where this has all evolved to. I'm going to talk to you about the Kidney Action Team trial. So in light of LIA 2, we really started believing like, okay, we need to give personalized recommendations for acute kidney injury at the time of the alert. We have to tell people, we have to give them an action to do. Some of those actions can be discontinuing medications, but there's lots of other stuff that might be needed as well. So we developed the Kidney Action Team trial. This is an AHRQ funded study with enrollment of 4,000 people. We completed enrollment 2 weeks ago, very exciting. So we are just collecting our final outcomes. I don't have the results, but hopefully at a conference coming to you soon, we'll be able to present these results. But the basic idea is that we can't just inform providers of AKI, we need to give them specific actions to take, and will providing those actions improve outcomes? And so this is essentially how the study works. So a patient in the hospital has AKI. The alert is not sent to the provider in this trial. It's sent to the Kidney Action Team. And the Kidney Action Team is a nephrologist and a pharmacist. So it's a team of 2. The team changes. There are a bunch of nephrologists who do this. We take shifts and a bunch of pharmacists who do it. So at any given time, the team can be whoever, but it's got those 2 people on it. The Kidney Action Team does an electronic chart review and creates individualized recommendations. Then, and only after they've made their recommendations, does randomization happen. So very key, they don't know a priori if this patient is getting randomized to their intervention or not. It's all sent into the system. Then they're randomized. If they're randomized to the intervention, I'll show you what happens. A note is populated into the electronic health record that's specific to that patient. If they are randomized to usual care, nothing happens. But importantly, we still know what the recommendations are. So we can kind of follow like whether the teams would have done those recommendations anyway, even if they didn't get them specifically. Okay. Recommendations are made across 5 broad categories. I'll give you some examples of the recommendations that are given. So for example, the team might recommend that you order a hemolysis or rhabdo workup, or just urinalysis, or monitor urine output, maybe checking toxic alcohols and so on. So a lot more than just stop NSAID in this study. And we tried to capture all of this as accurately as possible. And so this is the interface that the Kidney Action Team sees and fills in. So you can see here, it's very much point and click. They can just say, anion gap workup. They don't have to type it out. The only exception is the medications where there's some free text that the pharmacists put in. But everything like ordering loop diuretics and potassium binders and insulin and telemetry is just a simple click. Like, yes, this patient needs telemetry, which is good because it makes the Kidney Action Team more efficient, but it's also good because now I have that data in a structured format. And so I can say like, oh yeah, this person was recommended telemetry. Did they get telemetry or not? And so on. Those clicks, those check boxes are then imported into a formatted note. This is done automatically, so the team doesn't have to worry about this. But it looks like this, and it's nice, I think. It's a nice note in the chart. It's very standardized. It tells you in kind of checklist format what you should do in terms of diagnostic and volume and potassium management and acid base and so on. In this case, this patient has no specific potassium or acid base managements. So it's a checklist, but unlike Nick Selby's pioneering study, where the checklist is the same for everyone, this checklist is different for everyone because it's based on a chart review. It's actually pretty quick. People are surprised. We track how long it takes our physicians and pharmacists to do this. It's about 4 or 5 minutes. They don't have to They're not writing a full consult. They're not doing a physical exam. They just need to tell you what the next step are to get the ball sort of rolling in terms of AKI. It's pretty efficient. And people get randomized, within 25 minutes of AKI being developed, which is pretty good. I'm just showing you baseline characteristics. Now, not every patient with AKI is enrolled. Mostly this is because we can't staff the kidney action team 24/7. And so people slip through the cracks. So we do monitor the difference. And this is interim analysis, so it's not all 4,000 people who were enrolled, but we did start to see that there was sort of, we were a little bit concerned that the people who were getting enrolled were a little less sick, in part because we had been staffing kidney action teams for AM labs. And as you might expect, people who get AKI from their AM labs are not as sick as people who get AKI from other labs, because why are they getting other labs? Like, why are they getting PM labs? Why are they getting stat labs, et cetera? So we ended up changing our strategy in terms of recruitment to put more people on like weekends and nights and stuff like that. So this has improved a little bit, but almost everyone gets at least some recommendation. There's almost always something you can do for AKI, but potassium and acid base recommendations are quite a bit more rare. Not surprisingly, a lot of people have sort of normal potassiums. In fact, our most common potassium recommendation is to replete potassium. That's something that surprised me, but we saw it very early on in the study. And it's interesting because, by the time AKI comes to nephrology, it's quite a bit more severe than this. And we're often, worried about potassium. In this case, there's a lot of people with, fluid and volume losses that actually could benefit from some potassium. Lots of discontinuation of medications, 28%. Again, interim analysis here. 40% of dose adjustments, 12% had both. So there's lots of pharmacy benefit, we think. I'll skip through that in the interest of time, and just unstratified outcomes here in our interim analysis. So this is not the randomized, it's just overall outcomes, but you can see kind of what we'd expect: a little lower death rate, as I had implied, and progression rate and dialysis rate in the enrolled group at our interim analysis, which again led us to start staffing the teams, at times other than AM labs. And this has gotten closer to the overall AKI outcome rate. Just to show things are working, for example, here's the group that we think should have a creatine kinase, sorry, not creatinine kinase, creatine kinase, and then whether or not they did get a creatine kinase. Now, again, this is not stratified. Remember, we make recommendations on everyone. So this might be that the teams are doing the right thing. They also think the patient should have a creatine kinase and they get it. But also built into this is potentially us telling them to do it and they do it. We'll know when we unblind ourselves what this effect is. But you see similar things for, for example, our recommendations for echoes. But, nevertheless, there are people getting echoes that we don't think need an echo, for what it's worth. In terms of medication discontinuation, the blue here is the blue and red are people who do get those medications discontinued and those dosages changed. Again, this is not unblinded. This is just among those who we would recommend, including in the control group. And we got some feedback. Most people were actually pretty happy with this. Did you find the recommendations helpful? Survey, 117 people. Most people said yes. These are some of the answers. Of the 22 who didn't find it helpful, I don't think this patient has AKI. We actually reviewed all of these. They do have AKI, but it's just people think that like 0.6 to 1 is not AKI. I mean, it is technically. Almost done. We want to know if a computer can do this. That's, can we not have humans reviewing the charts? This is some work from William Zhang in our lab, and Aditya Biswas, who trained a neural network actually to simultaneously make all 43 possible recommendations. So instead of 43 individual models, it's one omnibus model making 43 recommendations. And you can basically see, for example, the performance across various outcomes here. This is how well the computer concords with the human kidney action team. So for example, for renal consult, the computer agrees or has an AUC of 0.8. Some things are almost deterministic, like telemetry, 0.99. It's very good at knowing who gets telemetry, probably because it's people with high potassium. It's just not that hard to predict. Some of these aren't so good, like, rhabdo, I guess, at 0.69. You know, again, I'm not entirely sure the kidney action team is the gold standard because we see a lot of variation even in the kidney action team from one provider to the next in terms of like what they're recommending. So, but I think this is an interesting future direction to predict all this, you know, in a single model and get that into the chart. I'm just going to rush and go to conclusions. So AKI alerts, like all alerts, have to pass the No Care Act Matter test to work. Many providers do not know their patient has AKI. Most providers care that their patient has AKI, but the big barriers are in these ACT and Matter domains. So we need to tell people what to do, and then what we tell them to do has to make a difference. Maybe greater personalization, either through Uplift modeling or these more very tailored recommendations like the kidney action team can lead to better outcomes. We'll let you know. Lots of people in the group here to thank in and out of Citra, and I will stop there exactly at 9 o'clock. Sorry, Swap.
This was really nice. Fantastic story. You could have kept on going for a long time with the stuff you've done. I have many questions, but I'll open it for others. Oh, Dr. Noel.
Yes, thanks. That was a great talk too. The kidney action team, I noticed on the top it said this is not a consult, but to me it looks better than a consult. A, it's much more timely, and B, you're getting a pharmacist at the same time.
Yeah.
And all those AUCs and things you showed with that, the AI model, I'm assuming you would get the same if you just had full nephrology consults. Right? Like even amongst us, right. You would probably end up getting the same thing. So I don't think it's anything about the CAT, but what really does the nephrology consult add on top of this, do you think?
Well, there's a couple of reasons for saying this is not a consult. Number one, we don't follow up. So, nephrology consult's going to say, get a urinalysis, and then they'll do an interpretation of the urinalysis. Our philosophy is get the ball rolling. The team is going to be responsible for this follow-up. That's also preserves blinding, right? Because we'd have to know, we'd have to go back. And so that's a major difference. We don't provide a differential diagnosis. So you'll note that note does not say, oh, we think this is ATN. Secretly, we capture this. We do ask the kidney action team on their form, what do you think is going on here? Mm-hmm. But we don't surface that because a lot of times, this is the moment the creatinine bumps. And I've done quite a number of these, obviously, and I don't know, I might think, maybe it's ATN, maybe it's prerenal, maybe it's contrast. I'm not very sure.
But I guess that was my point. I guess we kind of do that in our consults.
That's true. That is true. So maybe follow up is the major difference here. Yeah.
Very cool. Yeah, I'm looking forward to maybe Kidney Week, seeing you present that.
So are we. We'll see.
The conference room.
Thanks very much, Dr. Wilson. Mark Canny here, one of the nephrologists. I do apologize for the mind-boggling comment. I must have been in a bad mood that day, but and I'm only joking. I didn't review you. So I had two questions. One was the algorithm seems to pick out the peak and the nadir creatinine and over a time course. And so you will have patients who are sick and the creatinine falls. So let's say it's 0.9 drops to 0.5, comes back to 0.85, and technically that person has acute kidney injury, but I guess they were sick enough to drop their creatinine, and then the drop in the creatinine associates with an outcome. So I just want to know how you deal with that issue. And then the second one was with the Uplift modeling. I'm wondering, did you go back to your ELIA 2 and use something like prediction of individual treatment effect to tease out that hypothesis you had about the little old ladies?
Yeah, thank you. Both good questions. So in terms of the low creatinines, it was an early question for us whether these dips in creatinine should count or not. And we do include them. So the way our primary algorithm works is it looks at your current creatinine, and then it looks at the lowest in the past, time window, 48 hours or 7 days. So if you went from 1 to 0.7 to 1, we would call that AKI. Now, people say, oh, it's dilution or maybe actually acute illness is much more interesting to me. We don't think that that's dilution just because the math of how much fluid you need to give to get someone's creatinine to drop that much seems excessive, although less so when you start at higher creatinines. But we do include that, and it's an interesting hypothesis that it's not maybe the baseline creatinine or the muscle mass that's determining this, but the acuity of illness, which would comport which would comport a little bit with maybe the PPI group, which seems to be sicker. We have done but not published an Uplift model analysis of ALIA-2. I have a postdoc working on that, and I'm remembering, I think I'm not getting it wrong, that we still see that low creatinine finding in ALIA-2, but I will have to double check. And then I think that was your 2 questions, right? Is there something else?
Yeah, that was it.
Okay.
Can I, if there are no other questions from other people, can I ask one question? Is that, you've done all these alerts with Epic. How easy or hard, or do you have any tips on getting such kind of trials done? Do you need to have, connections with Epic in Wisconsin, or do you have your local Epic team at Yale, if that helps?
It was a little bit of both early on, but it's actually easier now. So when we started, there was no functionality in Epic to compare a current lab to the minimum in the prior X amount of time. That function didn't exist. Epic actually wrote that for us. That was very nice. Now it exists, so you don't need special code or anything like that if you have kind of the latest version of Epic. So no, this can be done internally. I think the major hurdles are, number one, it's really hard to do this type of trial without a waiver of informed consent because it has to happen in real time. And of course, if you consent someone, but that to an alert, but then they're in the control group, you're like, okay, you're in this trial because you have AKI, but don't tell anyone because you're in the control group. It just like doesn't work. So you really need to get a waiver. The other thing that is tricky is to make sure that once randomized, the person stays in the group they were assigned. That there's a bit of logic there that is not entirely straightforward, but if anyone's interested, just email me and we'll show you how to do it.
Fantastic. Yeah. Fortunately, our REB is good at understanding these things, and so we do get waiver of consent. And last question is, this Uplift modeling. I have a very high level question, or a low level question perhaps, is that you can use it in trials that are negative, overall negative, to start to figure out is maybe it works in some people, but you could also do it in trials that are positive.
Yeah.
Because normally our like you mentioned, our positive trial, all we do is let's implement Flozins in everyone, and
right.
Should we be looking at this even in positive trials? Again,
yeah.
Of course, this all depends on whether your trial works and etc.
Of course, yeah. I mean, there's no reason not to. We actually did it as a test in the Sprint trial data set, which was publicly available, an infamously positive trial, and can identify a group, multivariable subgroup that seems to really benefit from intensive blood pressure control. Honestly, the problem with it is that no one's interested in that. The pharmaceutical company does not want to know this, right? They don't want to limit their indication. They want to expand their indication. So it's honestly more from a public health standpoint and from a cost effectiveness standpoint that these types of analyses are useful. But you're going to want to validate it prospectively, and someone has to pay for that. And certainly the drug company is not going to. It is not in their interest in any sense. So then you need a national payer to agree to buy drug to just test it on one subpopulation of people. And it's like, it is a lift. I mean, maybe that's a sad state of affairs, but I think that's where we are.
Yeah, again, I somewhat agree with that. I wasn't the reviewer 3 either, but it's a little bit, it goes against our dogma, right? If it works, it works. You are not supposed to look at these groups to decide in whom it works and whom it does not work. I still, I'm waiting.
But what's interesting, I actually hid this slide, and maybe I shouldn't have. Sorry, I know we got to finish. Everyone can leave except Swap, but I'll just show you very quickly. Let me share. Okay, so here, this is an Uplift curve. So this is a curve of the primary outcomes avoided based on targeting ever more narrowly the population that the Uplift score defines. And so the orange line, the curve is bounded by, if we target everyone in the population, then the number of lives we save or primary outcomes averted is whatever the trial says. In this case, for the alerts, there were slightly more progression of AKI in the alert group, so we're negative here. And then, of course, if we don't target anyone, it's 0. So this end always ends at 0. And then what we do is we say, okay, if we narrow our target to ever smaller, the smaller proportion, how many actual progressions of AKI do we avoid? And it generates this curve. And so theoretically, like the peak of this curve is mathematically, and this is at the population level, right? It's not among the people you randomize. It's among everyone with AKI. How do we avoid the most AKI progression? And the answer is actually by targeting, let's say, 60%, but the right 60%. And so I actually think there's an ethical argument that maybe you have to do this because you're giving less people the drug or intervention, and you're saving more lives, not just in the people you're treating, but in the population as a whole. So like that's ethically a dominant strategy because it costs less and it saves more lives. So maybe the argument is like this is necessary.
Yeah, you're sort of persuading me a little bit from the edge, but I still want to see. These are hard. Hard beliefs that you have to let go, which is taking some time for me to adjust to. So I'm really looking forward to your trial that you just started recruiting.
I know. I am too. That one will not be a kidney week this year, but maybe next year.
For sure. Thanks again for doing this. This is a wonderful body of research. Delighted to have you here, and I'm looking forward to Kidney Week to see you.
All right, knock on wood, we'll see.
Up on the podium.
All right, take care, everybody. Thank you.